Well, thank you very much to all of our student contributions, both current and alumni students, and for sharing your reflections of your practice and your role transitions into the roles that you're currently in. We're missing one of you today, so Gavin Willicott, we hope that the house move has gone well and that you're okay in the middle of it all. And we'd like to welcome Kerry, Gavin and Judith here to the stage to answer some questions. So Kerry, if you don't mind, I will start with you. And
Yeah.
we were just wondering what your overall thoughts on managing your transition into your role has been.
So as you may have picked up in the presentation, I think we can organise these in both a personal and professional kind of areas. So for personally, obviously, it's those feelings of insecurity, feeling inadequate, and I talked about grief for my previous role. So I was quite an experienced registered nurse with over 25 years of experience, and I felt, oh, this is fine. And I felt really excited by the challenge of it. But obviously it's just managing that. You realize how difficult it is, and, just feeling totally overwhelmed and just feeling insecure and inadequate. I think a lot of the professional, within the professional domain, I think it's about that, having that clarity of the role. And for me, as an experienced nurse, I felt there was a lot of blurring of roles between being an actual nurse and, fundamentally, I am a nurse, of course, and I love being a nurse. But I think the advanced nurse practitioner role is quite a unique role, isn't it? But it's just initially I found that really difficult and really challenging, and also within the organisation, it was quite new. So I think trying to overcome some of the kind of misconceptions of the role, and just medical colleagues not fully understanding what we can do and the benefit that we can bring, and that holistic role. So yeah, those were some of my main thoughts, really. Yeah.
Thank you. Can I bring Gavin and Judith in on this? Have you felt the same thing? Have you been through the same types of issues?
Yeah, I think very similar to Kerry. When you start to work at a higher level and as you develop through your competencies, becoming more and more autonomous, and you start to lose that safety net a little bit. I think that becomes quite challenging, especially when you're working in, that hybrid model where you're still a nurse but you're doing a lot more that's historically considered medical. And a lot of probably unfair comparisons as well, comparing yourself to clinical supervisors who may be GPs with 25, 30 years experience. Is not a fair comparison, especially when you're still transitioning through the role yourself. I think to overcome that, you have to have a bit of realism about the stage you're at. You have to have a good bit of insight, and be quite reflective on that as well, and also use the support of those around you who, line managers or people who've been through this transition themselves, and get their perspective on things.
Absolutely. Judith, would you have anything to add?
Yeah, I agree with everything both of you have said. I found when I moved from a community setting to acute setting, because I have no medical staff within my team, so I needed to work alongside medical staff to increase my medical assessment, diagnosis and treatment skills. So I chose to walk away from my team, and that was very daunting, to work alongside medical staff within an acute respiratory ward. And I did feel very much like an imposter. Am I worthy of this? Who do I belong to? Am I a nurse? Am I a medic? And fluctuating between that. But as the 2 years have went on, I do feel much more comfortable in my role. I'm starting to feel more ownership of that, and finding that I'm able to take bits of nursing and medicine to develop my own independent practitioner role.
Oh, thank you for that. That's a really good insight into your roles there. Kerry, if I can come back to you, you mentioned a painting in your talk there. Can you, what reflections can you draw from that painting that you mentioned?
Yeah, so I guess it's kind of thinking about, you ask about the thought and how it's not just thought, it is how you feel as well. And as I've already said, I felt quite overwhelmed and anxious, and there's a really many of you may be familiar or may not, but you can Google this. It's a painting by Edvard Munch. I think I'm saying it right, in 1893, and it's really, the background is really strong orange bold colors, and it's coupled with in the center of the piece, just a person just looking absolutely in despair there, and I just thought, when I saw that, I thought, actually, that really just sums up kind of how I was feeling, just that inadequacy, the fear, the anxiety. And you know what? If I'm honest, some days I still feel like that, and that's okay, isn't it? Because we're human, and there are different challenges at each time, because our career is progressing. We're on this lifelong learning, and there's challenges that are going to come up. And we'll face them along our nursing, advanced nurse practitioner careers, won't we? So I just thought it was it depicted my kind of my thoughts and my thought process and my feelings, Anna.
Thank you, Kerry. Is there anything you'd like to add, Gavin or Judith? Nope, lovely, thank you. Judith, we'll move on to you if that's okay. I have a couple of questions for you here. You talked about each pillar having equal power. Now, that's an interesting concept, that with education and the use of pillars comes power. But how does that influence practice and care, do you think?
Clinical practice, I think needs to be underpinned by evidence-based practice, and that all starts with the roots of education and developing research pathways within our teams. And to me, that's all the core of enhancing the quality of care that we provide for our patients. And staff need to feel empowered to share their learning and their concerns. They need to be able to discuss those difficult cases in a safe, supportive learning environment. And I've always worked that ethos, that I'm very willing to put my hands up and say, oh, I don't know that, hold on, we check, or oh goodness, you're right, no, that's a better idea than what I had, you're following the right pathway. I'm very willing to put my hands up and admit when I'm not sure and when I need help. And I think as leaders as well, and we are becoming leaders now as advanced practitioners, we need to set that example. And for those that are less experienced and more junior than ourselves, need to learn from us and learn by our example. And I think staff that feel valued and well educated and listen to the needs of the patients, all they can do then is improve their service delivery. That underpins it. And I think having that open learning environment, having that protected time for staff to develop, giving them permission that it's okay not to have every minute of your day as in direct patient contact. There's other areas, and there's other areas of our practice and our pillars that is so important to influence that.
Absolutely, and that draws on conversations that were raised this morning from presentations there. So absolutely. Gavin or Kerry, would you like to add anything?
Do you want,
You okay with
Gavin,
that?
do you want to go?
Yeah, I just... Sorry, Kerry, on you go.
No, you go first. I'll go at the end. That's fine.
Okay. I think Judith's concept of it having equal power is very interesting, but I also think we'll like to... I don't know if it's because we like to visualise it, but having the pillars as very separate entities, they're absolutely not. I don't think you can impact one pillar without impacting at least two or three, probably all four. So they all have equal balance and as much as equal power. Yeah.
Yeah,
Absolutely. Kerry?
And I absolutely agree with that. I think I mentioned in mine that I see the pillars as very intrinsically linked, and obviously the clinical pillar is the most recognised because it's the most visible. But without the underpinning knowledge and education that can drive our practice, and having the education, having that that builds your confidence within the pillars. So it builds your confidence to go and do a piece of service improvement work and use your leadership skills and, you know, empower and, to transform services and practice, really. So they can't work independently of each other at all. Yeah, that's my thoughts too. So, yeah.
Thank you. Really interesting there. I'll come back to you, Judith, if that's okay. And you mentioned joint supervision and list that under leadership. So how important is supervision to you in such roles and in creation of teams?
Well, first of all, I work within a multidisciplinary team, so we have specialist nurse physios and specialist nurses working together, reviewing the patients in the same way. So we're a very integrated team, and professional development is essential for our team, and that's essential for service development. You know, staff need acknowledged in the good work they do. They need a safe environment to discuss their areas of concern, and we need to enable staff to identify their learning needs as individuals and within our own team, especially when we have nurse and physios working so closely together. And there's not one shoe fits all. There's loads of different methods we can use in our supervision. Like currently within our teams, we have one-to-one with our manager who may not be our professionals. Therefore, we also have it with our professional leads. We have it within our own group supervision within our professions. And we also have group supervision within our teams. So the nurses and physios working together to learn from each other, develop their service. And I feel, and it's you know, and that's been an example from my management, you know, very positive supervision sessions with my manager. And it's been essential to embed that into the teams to create that, and I've said it before, that safe, open, working, learning environment that we all need.
Thank you. Gavin, did you have anything to add to that? No. Kerry?
Just picking up on that, what you were saying there, Judith, around joint supervision, and I like some of your ideas there, and maybe we're not doing enough of that in my own area, because I have one-to-ones with my team, I have one-to-ones with my manager and my clinical supervisor, but I think we work very closely and integrated with the multidisciplinary team. So I think the group supervision and clinical peer supervision would be really useful, and that's something currently we're not doing, and I think we need to probably do more of that, because no profession can look after a patient in isolation, isn't it? We all know that. So that's a really good thing for me to take away, so thank you for that. Yeah,
That's great. Thank you all very much. Gavin, I'll come to you if that's all right. And a question for you is, does your CPD encompass support to maintain or develop skills across all pillars?
Good question.
Yeah.
Yeah, so so as we just spoke about, the pillars absolutely do not stand on their own. There's a blurring of the pillars right through. I think there's a focus on the clinical practice pillar, absolutely, and for good reason. We are very lucky in my organisation. We are well supported with CPD time, but also well supported by line managers and supervisors to access specific modules or CPD packages that we feel may need to develop our own leadership skills, our own research skills. And I think a big part of it is actually recognising what you're doing as leadership and research as well. And I think if you're not line managing somebody, you're often quite good to not recognise that as leadership, even though you may be providing clinical leadership quite obvious to somebody else.
Yeah, absolutely. Judith, would you have any reflections on that?
Yeah, definitely, as Gavin says, you know, it's very obvious when you're providing leadership, when you're supervising staff within a team, that's very obvious. But as specialists in our areas, we are providing leadership by everything we do every day, how we act, how we practice, the influences we provide. And that even became evident during my training. When I went into the acute setting, COVID was rife, and I was working in a COVID ward as opposed to a respiratory ward. And some of our overflow wards had less experienced staff looking after COVID patients, and I felt I need to go there, I need to help and support them. And I didn't realise afterwards I met someone in their different role once they had left from being redeployed, and how actually my influence, what the influence I had on those staff just by supporting and guiding them on the simplest task of looking after a very ill respiratory patient.
Absolutely. Thank you. Kerry, would you have anything to add?
Yeah, I guess I suppose within my own team that I do lead a team. So obviously there's clear leadership there, but what I do try to do for my team is give them some time so that they're not just all clinical all of the time, and I allow them time to work on their projects. Obviously, if there are shortages on the clinical, we do need, patient care comes first, but I do try to protect and give them chance. So things like, even improving documentation, somebody, they're quite an innovative team, and I'm very fortunate that I work with such an innovative team. So I think it's really important within your teams to try and get that protected time if you can, just because you need to evidence within your portfolio, isn't it? So, and build that into your working week somehow. And I try to do
Fabulous.
that.
Yeah, thank you, Kerry. That's a really good answer there. We have a generic question from the audience. Thank you, Sarah. Did you have trained advanced practitioners as clinical supervisors alongside medical staff? If not, would you have felt that that would have been an advantage to your transitioning? Really good question. So maybe if I can go to Gavin first.
Yeah, so my direct clinical supervision is delivered by GPs. So I mentioned in the presentation, we work across health boards, split half our time between NHS24 and the digital environment, and half the week out in primary care. So my clinical supervision is primarily delivered by GPs. However, I have mentorship from a trained ANP within the organisation, and a very compact team that are all very supportive of each other too. Absolutely, it would have been beneficial to have clinical supervision delivered by trained ANPs in regards to clinical skills. Developing networks with the partner health boards and more laterally working with different ANPs across different disciplines and different specialties, I feel like I've not learned more, but I've learned differently than I have done from working with medical colleagues. Absolutely.
That's so true.
Yeah, indeed. Kerry, I'll bring you in there if that's all right. Thank you.
Yeah. So I was lucky. I did have my line manager was a trained advanced nurse practitioner, and she was also one of my supervising practitioners. And I think it was really important because my clinical medical supervisor, they are very medically focused, and you're working on a very medical model. That was completely new to me. But my nurse, advanced nurse practitioner supervisor, she always brought it back to tell me more about that, rather than just being really focused on a medical model. So I think you do, that was so important to me.
Absolutely. And Judith?
Well, my supervisor is a respiratory consultant, and I had no real other option as I am the first ANP within. There's two of us this year within adult and older people in our directorate, and also the first within myself. Another male is a first within respiratory services within Northern Ireland. So this is all very new to us. So it would be great going forward if we had advanced nurse practitioners alongside our medical colleagues, like a dual supervision role to help support us develop that role alongside the increasing of, and we do need a certain amount of increasing our medical assessment skills to work down a more advanced practice, but we also need the guidance from more qualified, experienced advanced practitioners. But that'll be the future as hopefully more roles are developed within Northern Ireland.
Thank you all very much. We've got about a minute left, so I'm going to squeeze in a question, if that's all right, and then I'll draw us to a close. So thank you, Adele. To the panel, do you feel adequate weighting was given to the pillars of research, education, leadership and management during your MSc ACP? And have you had the opportunities to be innovative? Really good question there. So Judith, if I can start with you, please. Thank you.
Yeah, I think the structure of our Advanced Nurse Practitioner Masters module 2-year course within UU is very structured, and that has been evident from the start. When I first came into the course, I thought this would be a very clinical role, and from that I realised that there's an awful lot more to it, including the 4 pillars. And I have been allowed by my managers and by my supervisor to take my role in the direction I want to, which has been great.
That's great. I'm afraid I'm going to need to draw this session to a close, but thank you ever so much, the 3 of you, and to Gavin, who's not here today, for your presentations. It's been really informative. So thank you very much on behalf of AAPE and of our delegates who are watching.